Hey everyone, so I thought I would throw in a little extra PowerPoint, kind of a down and dirty cardiac patient, and what you'll see, what you'll do um, type of PowerPoint, so I'll help you study a little bit. Alright, so when you have a cardiac patient, regardless of what their disease process is, you're going to do a visual assessment. You'll do a set of vitals to find out your baseline. You're going to do a neurological status. You're going to find out if they're alert and oriented, whether or not they're lethargic or not. This is actually going to kind of tell you how their mental status is at that time when you actually assess them. You're going to look for jugular vein distension. This will kind of show whether or not they're having high blood pressure or there's a lot of fluid buildup. You're going to do a assessment on their heart sounds. You'll hear the S1, S2. You may possibly hear a murmur if they have one. You're going to listen to lung sounds. You're going to find out if they're clear in all the bases and all the lobes, or you're actually going to hear some crackles or wheezing, or you may actually hear clear in the upper and dim in the lower. This will kind of tell you how their breathing is going to be. You're also going to do a assessment on their radial and pedal pulses. This is going to tell you whether or not they're actually bounding or if they're slightly thready or diminished. This will tell you how their heart is actually beating. You're going to check them overall for edema, but especially their legs. If they have edematous legs, this might be a sign of congestive heart failure. And then you're going to check their psychological status. This is going to tell you, again, if they're anxious or if they're alert and oriented, if they're depressed. It kind of tells you where they are in the process of what is going on right now with them. You're going to look at their labs. You're going to do a CBC. You're going to do a BMP. You're going to do a BNP, which is going to tell you what their breathing or their respiratory or cardiac status is. You're going to do a PT and INR. This will actually tell you whether or not their blood is too thick or too thin. You'll do a PTT, which you'll do for patients who are actually on heparin. You'll do a CK, which is the CK and the troponin, which are the two labs that will tell you whether or not something's going wrong with the heart or if there's been some sort of change in the muscle itself. Because again, that muscle change will release proteins, which will actually excrete into the bloodstream. Diagnostic testings, again, you're going to do a set of vitals. You might do a 12-lead EKG, or you may put them on a telemonitor to find out what their baseline is or what their heart is running at that point. You'll do a chest x-ray to find out how their lungs are doing or also how their heart looks. You'll do an echo to do a 3D imaging of the atrium and the ventricles and also the valves to see if they're working properly. You may possibly do a stress test to find out if their heart, based on being stressed, is efficiently pumping. You may also do a Doppler or an ultrasound of their extremities to find out if there's any sort of blood clot or deep vein thrombosis or embolus, just to see if it's occluding the blood somewhere. Medications, blood pressure medication. You possibly may do lisinopril, metoprolol, cardizem. Those are medications that will actually lower the blood pressure. Digoxin, in my mind, is more of a medication to be used to help with the contractility of the heart to make it pump better or more efficient. You may give your patient diuretics, especially Lasix. This is to help pull the fluid off. So that way their heart is not having to beat so much. Lasix is also given to patients that are in fluid volume overload or their lungs are full of fluid. They'll pull that fluid back into the vascular space and the kidneys will secrete it. Antiplatelets and anticoagulants. You have aspirin, which you can give patients that are having a myocardial infarction, or as a dose of 81 milligrams baby aspirin every day, just to kind of prophylactically keep them from having a heart attack and keep their blood thin. The patient might also be on Plavix, which will also thin their blood. Coumadin is for those patients who either have had blood clots in the past, or have had a mitral valve replaced, or possibly, let's see here, what else, or AFib. because again, with AFib, the heart is actually quivering instead of contracting. That quivering will cause blood to churn and cause a blood clot. The Coumadin will keep that from sticking together and prevent it from having a blood clot. Levodox is a short-acting 12-hour either prophylaxis for patients who are stuck in bed, who might be prone to getting blood clots or could get a blood clot, or patients who come in who have a blood clot will be put on this first until their blood is thin enough so they can be put on Coumadin for a longer period of time. Heparin, again, they can give these to patients who either want to thin their blood as a prophylaxis or possibly put them on an IV drip in order to help thin that blood enough so the clots aren't sticking together. Again, these are not clot busting medications, but they will actually keep their blood thin enough and keep the platelets from sticking together and dissolve what is actually there to make it smaller until it goes away. TPA is the actual clot busting medication. It's usually given IV, and it's usually given for patients who are having some sort of clot in their brain or possibly a clot, but TPA is not used very often in the med-surg setting. And I think that's it. So again, 6.5 minutes worth of down and dirty cardiac patients.